let's begin. Dr. Komrad, Mark Komrad, is an ethicist in residence at the Shepherd Pratt Health and Systems, where he chaired the Ethics Committee for over 20 years. He's on the faculty of Johns Hopkins and University of Maryland, member of the APA Assembly, and previously served 6 years on the APA Ethics Committee. In these two capacities, he helped craft the new APA position statement just approved this past December. Quote, a psychiatrist should not prescribe or administer any intervention to a non-terminally ill person for the purposes of causing death. He's lectured widely through the United States and Canada and Europe to address the ethical concerns that several hundred suicidal psychiatric patients in Belgium and the Netherlands are being voluntarily euthanized each year with lethal injections. I assume you will cover much of this, so I think I will shorten it to let you say it with more emphasis than I would. I will want to say that as he's speaking today, his CV is online. Take a look at it. His experience is incredibly deep and long in this regard, and he told me beforehand that this issue has really transformed your career, your vocation. So after he speaks today, you know, there'll be a moment for silent reflection. We will have time for questions, but we may go a few minutes late, just for a few more times for questions today, because the presentation is about an hour. The title of his talk today is Physician-Assisted Suicide and Euthanasia of Non-Terminal Psychiatric Patients, an Emerging Ethical Crisis. Dr. Komrad, thank you for coming.
Thank you all for inviting me. I think that it's a wonderful opportunity for me to meet you all and learn about you all, because I really sense that I've found some people that I can really resonate with, though we may disagree about this particular issue. As you've heard, I'm actually, in addition to a practicing psychiatrist, I am a medical ethicist, and I've been for 30 years. And I'm chair of ethics at Shepherd Pratt. I've been involved nationally and internationally in medical ethics in general, psychiatric ethics in particular. So, as a matter of fact, usually I show this slide to audiences when it says we're all friends here, try to forget that I'm an ethicist. Except in this particular group, we're all ethicists. So I'm particularly delighted to be among a resonant family of thinkers here, and I appreciate that. I do understand that you all, as a national society and as a local society, have actually made a formal endorsement of physician-assisted suicide, or what you all call death with dignity, and under the circumstances in which it's being practiced here in the United States. And I'm going to talk a lot about what's happening in some other countries here. And I'm going to speak to you from a little bit different point of view, which I'm very grateful that you've come to hear, and that Paul Firth invited me to come and present to you. He said we need to hear some alternative points of view. I'm going to speak to you from the point of view of a medical ethicist steeped in a very venerable 2,500-year-old ethical tradition of our own, which is that of the medical profession and medical ethics, and also as a practicing clinician who not only absorbed that in my training, but tries to manifest that ethical tradition, which is actually in the very definition of what it means to be a profession, because a profession is, by definition, a group that professes a certain set of values. And medicine has been professing a set of values since 2,500 years ago, and I'll show you some of those values. In fact, I was just noticing in this song that we sang together, you must have a code that you can live by. And indeed, we in the medical profession have a code that we live by. In fact, I'll show you what some of the professional codes of medicine have to say about this issue. So as much as I would like to carry on the theme of the hot air balloon and the joy and exhilaration of that, unfortunately, instead, I'm going to channel Melville, who writes in Moby Dick, woe to him who seeks to please rather than to appall. And it is unfortunately, but nevertheless necessarily my duty this morning to appall you, because this is an issue that has appalled me. So, in fact, as we heard, this is an issue that has transformed me. Heretofore, for most of the last 30 years, I have been a teacher, a scholar, a writer, a consultant on ethical cases in medicine, and especially in psychiatry. But I have stumbled across this issue, and you'll see what I mean by stumbled in a moment, in such a way that for the first time in my life, it has transformed me into an activist, something I've never been before. And so I'm going to communicate to you the passion of an activist. So I want you to be prepared for a Jeremiah kind of tone that may come across today. But I think that I'm going to try to make an intellectual case for where my passion comes from. Yes. All right, so I am a psychiatrist, and I really want to say that, and a philosopher. And so, as Camus said, there's but one truly serious philosophical problem, and that is suicide. And I want you to all understand that as a psychiatrist, I see the topic that we're talking about today to be nothing more or less than a topic that occupies me every single day of my professional life, which is suicide. And in fact, if you look at this Centers for Disease Control definition, suicide is death caused by self-directed behavior with an intent to die. It's very straightforward, and that is indeed what we're talking about here, self-directed behavior with an intent to die. So this is one of the reasons why, as a psychiatrist, I have some very specific points of view about what happens and how we should relate to people who have chosen to end their own lives. But I have, as a medical ethicist and as a psychiatrist, an even stronger point of view when it comes to a person asking me, as a physician, to take their life, not to get death out of the way, but actually to administer death to them. So, frankly, I have to admit to you that this is an issue that I'm going to talk about today that has been hiding in plain sight. Not physician-assisted suicide, but this. This came into my inbox, and I apologize for some reason the projector's cutting off an edge of the screen, but in June 2015, I found this article in my inbox from the New Yorker, The Death Treatment. When should people with non-terminal illness be helped to die? That in Belgium, that there's a law allowing patients with severe and incurable stress, including psychological disorders, to have euthanasia. We'll define that term in a moment. I had no idea that my guys, my patients, were actually being helped to die by physicians, as a matter of fact, most of the time by their own treating psychiatrists, who had been treating them and trying to prevent their suicide for years. I was pretty shocked. Then, in the Washington Post, Charles Lane, and he and I have since become friends and collaborators, if you were a psychiatrist and a chronically depressed patient told you he wanted to die, what would you do? In Belgium, you might prescribe this vulnerable, desperate person a fatal dose of sodium thiopental. Poking around further, I came across this remarkable documentary, which I commend to you all. It's 35 minutes long, made by The Economist, and it follows this woman, Emily, as she receives her approval for euthanasia for a psychiatric-only disorder. And I've cobbled together a 3-minute montage of this that I want to share with you.
I'm 24 years old and I'm from Belgium. And this documentary is about my request for euthanasia because of mental suffering. And when you see this documentary, I won't be here anymore.
When it comes to doctor-assisted dying, Belgium has the most liberal laws in the world. This is Emily's story. From the outside, she's a physically healthy young woman with a loving family and friends. It appears Emily has everything to live for, but she finds her life unbearable. In 2013, there were more than 1,800 doctor-assisted deaths in Belgium. While 97% of cases involved people suffering terminal or chronic physical illness, 3% were people suffering psychiatric disorders, the most extreme and controversial form of assisted suicide. Belgium is one of only 2 countries that allow it. Strict criteria have to be met before doctor-assisted death is allowed. Emily's case has to go through dozens of medical professionals and ultimately be signed off by 3 doctors, one of whom is psychiatrist Dr. Lieve Tienpont.
weet niet of dat jij nu op dit moment, zit je zelf met vragen die je wilt besproken zien?
Voor mezelf de laatste weken is de destructiviteit ook weer serieus toegenomen.
Emily started her application to end her life nearly 2 years ago.
Ik denk dat de meeste, of om niet te zeggen eigenlijk alle mensen met een euthanasievraag op basis van psychisch lijden, hebben een lang verhaal van psychisch lijden. Dus dat is helemaal verschillend van iemand die een acute depressie doet, bijvoorbeeld naar aanleiding van een rouw. Dat is juist de inschatting van de artsen en de 3 artsen die met de patiënt bezig zijn. Want binnen psychiatrie, de mogelijkheden zijn oneindig. Medicatie, combinatie van medicatie met ambulante residentiële therapieën kunnen we verder doen. Maar het moeten eerlijke kansen zijn waarvan we echt weten dat het perspectief kan bieden. En bij sommige mensen hebben we die niet, zoals we dat in sommige kankersituaties ook niet meer hebben. Is dat ook zo bij psychisch lijden. Soms hebben we niet meer, niks meer te bieden.
So this is available on YouTube, 24 and Ready to Die. And I'm going to give you a spoiler. So they follow her, saying goodbye, mugging across the rooftops of Belgium, sitting with her friends, everybody's crying, and over some weeks, and finally the psychiatrist comes to her bedside to start an IV, because as I'm going to explain to you, that's the way it's done outside of America, is they actually give an IV injection, just like in capital punishment. And ultimately, on that day, she decides to relent, and she does not go through with the procedure. Apparently, being the subject of an Economist documentary gave her a whole new meaning of life and turned to be a therapeutic thing. And by the way, this is one of the arguments. One of the arguments of proponents is that leading people to the edge and allowing them to peer over the edge is potentially therapeutic. To give them that option so that they will perhaps reconsider staring into the abyss and maybe some of the things that are done towards the end that should have been done all along can be sufficiently galvanizing to turn around that choice, and that's what happened with Emily. So I felt like I missed the memo on this. This is something that had been hiding in plain sight, and here I am, a medical ethicist. I had no idea they were actually killing psychiatric patients in Europe, it turns out, both Belgium and the Netherlands, as I'll show you. So let's dive in a little bit here. Let's first begin by defining our terms. The Red Queen in Alice in Wonderland says, a word means what I want it to mean, nothing more and nothing less. And as you know, in these highly contentious issues, people throw about all sorts of words. My mentor, Dan Callahan of the Hastings Center, calls it organized obfuscations. We have terms like physician-assisted suicide, voluntary euthanasia, compassionate assistance to die, physician-assisted dying. In Canada, they call it MAID, medical aid in dying, death with dignity, medical murder. Dr. Kevorkian of infamy, a couple of decades ago, tried to stand up the term medicide unsuccessfully. And then there's this organization of the World Federation of Right to Die societies that's now pushing the term dignicide. And the medical director of that organization, I think, makes the point powerfully. He says, I always refrain from using the term killing. You terminate life. And actually, more than that, you terminate the suffering. Get used to that idea because it's counter-human a little bit. So the Orwellian twist in the power of language, and again, it's not unique to this particular debate, but can really transform the way people think about it and actually lead to, and I just wrote an article about this, a whole phenomenon of moral detachment, which language allows, and we've seen that before in history. Sorry about this, I went a little bit fast here. My grandkids came to visit. They talked mostly about world politics, and they kept asking me how I felt about the youth in Asia. The use of language. All right, so let's define our terms. So there are kind of 3 levels in order of increasing moral complexity. The first, which is generally called assisted dying or passive euthanasia. That's really where the current state of the art is in ethics, where the withdrawal of treatment and the provision of palliative care. And the state of the art of palliative care is really quite robust, and if any of you have had any experience with the Gilchrist Center here in Baltimore, you have had some exposure to what actually we can provide in terms of comfort and minimizing suffering, support of demoralization of patients and their families. So that's sometimes called passive euthanasia or assisted dying. The next term, the next level of moral complexity is physician-assisted suicide. That is where the United States is at in now 8 jurisdictions. That's where the doctor provides a prescription and the patient goes and takes that prescription at the time and place of his or her own choosing, provided that your suicidal granddaughter doesn't get into your stash in the top of the closet while you're waiting to use it. It doesn't have to be witnessed or can be witnessed, but most of the laws don't require any professional or objective witness, so we have no guarantees about coercion or misuse or diversion. But that's the state of the practice here in some states in the United States. Then the third level, which is euthanasia, or active euthanasia. There, the doctor is present, starts an IV, and pushes a lethal drug into your veins and kills you. Now, we're going to focus primarily on these last two in today's discussion, but it's interesting, Neil Gorsuch, who actually wrote the definitive book about the legal and ethical morals, as most of us who think about this, he was very admired for this book long before he was chosen for the Supreme Court. And he points out that this distinction between these last two, assisted suicide and euthanasia, is actually a relative new distinction in American discourse in the last couple of years. Matter of fact, the Europeans who do active euthanasia and the Canadians feel that in many ways it's morally somewhat suspect in the United States that doctors don't have the temerity to actually sit with the patient and actively kill them and can remove themselves from the act by handing a piece of paper and then the person goes away to use it or not use it. And they actually criticize us for lack of moral integrity in that regard. But Gorsuch points out those distinctions are relatively recent, maybe to allow us to get away with something that otherwise we wouldn't be able to as easily get away with here. But look, the point is the basic paradigm, and seeing this as a clinician, as a psychiatrist, is we have a patient, and the patient wants to die. And we call that, in my profession, suicidal. So a person who wants to die and wants to end their lives is suicidal. So they ask the physician, and the physician creates a treatment plan where the purpose of the treatment plan is to administer death. And that is the paradigm in these physician-assisted suicide and euthanasia. There tend to be three distinctions in this discussion: the distinction between terminal and non-terminal illness, the distinction between whether you take it yourself or the doctor gives it to you, as I've explained, and also the distinctions between, I didn't include here, physical and mental suffering. Those distinctions have actually been removed in some countries, and the distinctions between psychiatric conditions and medical conditions, an ironic place to return to because we in psychiatry have been promoting for the last several decades an effacement of that last distinction, to be able to see psychiatric conditions as just another form of a medical condition and therefore should have parity in terms of how insurance covers it, in terms of access to care, and so forth. And interestingly, what we're seeing now is an ironic and unexpected outcome of effacing that distinction. And that once you say, okay, well, if it's just another medical conditions, let those folks get in line too when they have insufferable and untreatable conditions. So what I want to focus on now, though, and my primary interest, obviously, as a psychiatrist, is in patients who don't have terminal illnesses, who have psychiatric conditions. Let me give you a brief and important history here about this. I always find it a little bit ironic that the person who coined the term euthanasia was named Comicus. Euthanasia actually simply meant a good death. Its original definition was not putting someone to death, but a good death. Well, the ancient Greek myth is that Medusa, that snaky-headed goddess who could turn you to stone with a glance, that she had very effective blood in her. And Athena drew blood from each side of her neck. One side was a life-giving elixir, the other side was a deadly poison. And the god of medicine, Asclepius, was given both vials. And many, many cults of Asclepius existed in ancient Greece. And that is where medicine was practiced, in the groves of Asclepius, in different Asclepia or an Asclepion. And in those places, in most of ancient Greece, euthanasia was practiced for certain patients. And so both life-giving and life-taking was practiced, with one exception. There was one Asclepion, and that was the Asclepion of Hippocrates. Now, to be a member of a physician in Hippocrates' Asclepion, as well as to be treated there, one had to actually profess a set of values, to take an oath. It was the only Asclepion that asked you to profess a value, to have a code that you can live by. And that became the Hippocratic Oath, an oath that is taken by physicians throughout the world, as a matter of fact, upon graduation from medical school. I did, and the generations before me and after me continue to. One of the core features of that oath was what distinguished the Hippocratic Asclepion from the others. And that core feature is this part of the oath: I will not give a fatal drug to anyone if I'm asked, neither will I counsel any man to do so. So, this is the foundation out of which the mighty tree of medicine has grown over the last 2,500 years. Much like there were many cults, apocalyptic and messianic cults around the year zero, one of which is the cult of Jesus Christ, became the soil out of which the mighty tree of Christianity has grown, and has preserved many of the fundamental values of their original teacher, Jesus, in its worldview and its value system. Same thing with medicine, that we have preserved. We are a Hippocratic tradition. This is the origins of medicine, and has really suffused the boards out of which the House of Medicine has been built ever since. And yet, people have tried to challenge that and dismantle that, and that has been part of our bane over the course of the years. Now, I want to fast forward here to a little bit more contemporary history, because we can't talk about this topic without stopping here. It turns out that the person who coined the term death with dignity was a psychiatrist. And you need to know the context in which that was coined. Alfred Hoch, he wrote an infamous book called Allowing the Destruction of Life Unworthy of Life. He articulated the idea that there may actually be some lives that were not worth living, unworthy of living. This actually became the intellectual Bible that Hitler admired and used in the Holocaust. So in this book, Alfred Hoch, a psychiatrist, remember, said, not even the Hippocratic Oath is really binding anymore. The intellectual level of the mentally ill person is that of low animal life. Such individuals are not just absolutely worthless, but they're of negative values. And we doctors know that in the interest of the whole human organism, single less valuable members have to be abandoned and pushed out. And Hitler, quoting somewhat from Hoch, said, it's right that the worthless lives of such creatures, the mentally ill, should be ended, and that this would result in certain savings in terms of hospitals, doctors, and nursing staff. So this is the ignominious part of the history of this issue, and it resulted in the Nazi T4 program, which was the start of the Holocaust, which deliberately targeted the mentally ill and the intellectually disabled, developed the techniques of mass destruction, which were developed by psychiatrists. As a matter of fact, I'd welcome an opportunity to come back and give you the sequel to this talk, or maybe the prequel, which is going over that history of Nazi Germany, the role of psychiatry, and also the role of psychiatry in the United States in the eugenics and sterilization movement, which was the precursor to that. So the T4 program, named after the address here in Gartenstrasse 4, a Jewish mansion that they took over, by the time it was done, it had killed 400,000 mentally ill people. That was involuntarily, of course. So the great psychiatrist Leo Alexander was the physician who was asked to interview all of the Nazi doctors for the so-called doctor's trial at Nuremberg. And he ended up writing up his findings of his 2 years of interviewing these guys before their trial, and published this famous article in the New England Journal in 1949. And I want to quote you from that article, one of his conclusions. The beginnings of the Nazi doctors were first a mere subtle shift in emphasis in the basic attitude of physicians. It started with the acceptance of the attitude, basic in the euthanasia movement of the time, that there is such a thing as a life not worthy to be lived. This attitude in early stages concerned itself merely with the severely and chronically ill. Gradually, the sphere was enlarged to encompass the socially unproductive, the ideologically unwanted, the racially unwanted, and finally all non-Germans. And here's the most important point. It is important to realize that the infinitely small, wedged-in level from which the entire trend of mind received its impetus was the attitude towards the non-rehabilitatable sick. And that is what initiates a remarkable slippery slope, which I'm going to show you is going on even as we speak. So let's jump forward. The contemporary era, here's Dr. Kevorkian himself smiling with his apparatus that he developed in the 80s. Let's start with what's happening in this country. This country, we have these jurisdictions, 8 jurisdictions. Hawaii just a couple of weeks ago joined. Again, it's physician-assisted suicide here, not euthanasia, that's second level. There are no requirements whatsoever for any kind of mental health assessment. It's left up to the doctor who is treating the patient to decide, do they have a psychiatric disorder? Are they competent? And by the way, competency evaluation is a very specialized thing that actually happens to lie in the wheelhouse of psychiatry. Patients can refuse treatments and make themselves terminal. So none of the laws have anything to do with how you become terminal. If you have chronic diabetes and you want to stop your diabetic medicine, or if you want to stop your dialysis and you become terminally ill, you're terminally ill, and so now you've entered the zone of eligibility, possibly. And it's hard to do research because you're not allowed to list assisted suicide or physician-assisted suicide on the death certificate. You have to list the underlying illness for which the lethal prescription was justified. And again, no witnesses to know whether a person's been coerced or not. However, most of the time that these bills are raised, they are rejected. It's been raised since 1994. Actually, the number is now up to 240 in 36 states. It's been rejected since then in many, many legislatures. And as a matter of fact, the interesting thing is some states have tried to inoculate themselves against wanting this introduced. So in South Dakota, for example, they came up with a joint House and Senate resolution that we oppose physician-assisted suicide, don't even think about introducing a bill here, kind of a preventative measure. In Utah, they just in February re-emphasized, passed a statute that said assisted suicide is manslaughter. So they also said that they don't want it. And currently in the House of Congress, in the House, they passed a resolution that the federal government should not adopt or encourage or facilitate assisted suicide by physicians. So in other words, don't try to bring a bill here at the national level. Now you can think about politics, and you can think about how this arrays with other positions that are afoot these days in legislatures, but just to let you know what the history of the law in this country has been and what you think about it. Now, there's certainly people who are off the reservation helping people to die, including psychiatric patients. This group called the Final Exit Network with Derek Humphrey wrote this book, Follow My Instructions for a Perfect Death. No mess, no autopsy, no postmortem. These are the people who will come to your house and help you equip yourself with a helium tank, helium bag to put over your head. Lawrence Egbert, who's died not from physician-assisted suicide or any other, even from the Final Exit Network. He's passed away. But I commend you to this Frontline documentary, which is also available online. the suicide plan. And one of the cases they look at here is this very psychiatrically ill woman, Jana von Voris, who the Final Exit Network, without really much investigation into the nature of her problems, just on paper, approved her getting the helium tanks, and they went and they helped her to die. So this is happening kind of off the books. Now let's look at Canada. So in Canada, there was a case called Carter versus Canada several years ago, a case of spinal stenosis and ALS, neither of which were terminally ill. And in that case, the Supreme Court heard the case and said that according to their interpretation of their charter, which is their version of the Constitution, that assisted suicide and euthanasia ought to be a right of citizens. So they instructed Canada to craft a national law permitting medical aid in dying. And they didn't say just for the terminally ill. They said they were wishy-washy. They invented their own term there that none of the rest of the world uses, that it's people whose death is in the foreseeable future. And they didn't define that. It's a little broader than just, the 6 to 12 months that generally terminally ill is accepted. So in June 2016, they developed their federal C14 law. They said that if a person's condition was grievous, meaning they couldn't stand it, and irremediable, meaning that there were no treatments for it, that they could be eligible. And the patient's claim that they couldn't suffer their condition, that's irrefutable. That's up to the patient. However, in terms of whether it's untreatable, that's not just the medical team's determination. The patient can determine that. That's already an ethical norm, by the way, the right to refuse treatment. So a patient can say, well, I understand you've got this treatment for me, this chemotherapy, or this electroconvulsive therapy, or antipsychotic that might be able to help me, but my answer is no, I don't want to take it, and if that's all you've got for me, then I guess I'm untreatable. And all the countries that have these laws, that is the nature of the law. That untreatable can also be defined by the patient, not just by the medical community. I told you about the reasonable, foreseeable future. And this language is thought to implicitly exclude mental illness in Canada, but not explicitly, and there's a huge activism there to try to include the mentally ill there. This just shows you the debate that's going on. There's one organization of made assessors and providers of healthcare professionals that want to learn and want to administer this, and they're having conferences on it. And then another organization, the Physician Alliance Against Euthanasia. So many of the physicians who've been doing this, and by the way, I didn't mention in the slide that in Canada, unlike the United States, it's euthanasia. 97% of the cases there, the doctor is starting an IV, pushing the IV, killing the patient. It's not done by paper for the most part in Canada like it is done here. So doctors have found that very traumatic. A number of them are saying, we want out, take my name off the list, I don't want to participate. But here, ladies and gentlemen, is really where the whole emerging phenomena is in the 2.0 phase. I call this euthanasia 2.0. And that is that conscientious objection by physicians to not want to participate in the chain of referral is now starting to become an anathema and starting to be legally prohibited in Canada. So first, the College of Physicians and Surgeons said that if a doctor doesn't want to be part of it, you must provide a referral, and said that it would be unethical to not provide a referral. It would be abandoning your patient. It's a very bad ethical thing in medical ethics, to be abandoning your patient. So if you didn't want to do it, you need to point to somebody who would. And then, just in January, an Ontario court ruled that it was really not legally acceptable to be a conscientious objector, that you had to participate in a referral. This oncologist and medical ethicist are even trying to kind of redefine conscientious objection as sort of moral wishy-washiness, as emotionalism. and that really they wrote this whole article that conscientious objection is a mere loophole to justify a refusal, and that it's more about squeamishness rather than principle. So these are the developing ideas that are emerging as this tsunami of shift that is occurring in Canada, and thousands of people have, I mean, they're way ahead in just a single year. More people have been killed by physicians in Canada in 1 year than in the entire history of the United States, going back to Oregon in the 1980s. Canada has really caught up, and there are emerging moral reconstitutions of the sense of where the fulcrum lies between murder and mercy in Canada. And those who feel that they're conscientiously objecting to this are starting to be vilified. This is a Canadian series. It's actually now on Lifetime here in the Lifetime channel here in Maryland, called Mary Kills People. And it's actually set in the United States, in a place where it's not legal to give physician-assisted suicide, but Mary is an ER physician who's running a practice, a underground practice, in which she is heroically and seen as a hero, killing people at their desire. And the show is actually showing the slippery slope, because it starts with extremely terminally ill people, and now it's up to killing, also to allow the euthanasia of the spouse of the terminally ill person, so that they can go together, and even people who are experiencing grief from the loss of loved ones, not just a medical illness, which is how it is going in Europe. So let's turn to Europe now and look at the Low Countries. All three of these countries, in 2002, Luxembourg in 2009, made some very important laws. They legalized euthanasia, okay, which is the intravenous approach. They took away two important distinctions: the distinction between terminal illness and non-terminal illness, and the distinction between physical and mental suffering. Suffering is suffering is suffering, and you can't give the privilege to one group of people, like the terminally ill, without allowing everybody else to potentially have access to the privilege. So they said, like Canada, they were before Canada, long before Canada, that if a condition was untreatable, and again, defined by both the doctor and the patient can refuse, and insufferable, which is the patient themselves, I just can't stand it. Those can trigger the potential eligibility for euthanasia. They do allow advance directives there, which we don't allow here in the US or in Canada, so you can say years in advance, if I get dementia, and dementia is allowed there, I'd like to be euthanized. So I'm giving an advance directive, and almost all of them, 95%, are by lethal injections there. Let's look at some of the data coming out of these places. So the Netherlands, you can see here, since 2005, in the Netherlands, there's been a 400% increase in euthanasias there. In fact, in 2016, the data just shows that it's 6,000. And in fact, in 2017, the data just came out, and it's gone up by another 600 or so that have succumbed. You know, fundamentally, 4 out of every 100 human beings in the Netherlands dies at the hands of a physician. 4 out of every 100 dies because their doctor killed them on request. Now, what about psychiatry? In the Netherlands, you can see there's been quite a growth, about 60 in 2016. About 1% of all of those euthanasias are psychiatric-only patients. So in the Netherlands, there are 2 paths. One path is through your personal physician. The other path is a special clinic. And generally, that clinic is used if your physician doesn't want to do it, so that you have an alternative, Leven the clinic. And as a result, really, the proportion of people dying by euthanasia in the Netherlands is so high because of this alternative. Now, if we look at just psychiatric patients, let's look at the two paths who've been killed by their own doctors. Here's one study between 2 years, of 2011 to 13, where 66 patients were euthanized. Half of them had what we call personality disorders, which are really conditions of traits as opposed to states like depression or psychosis. Over half refused one or more recommended treatment. Remember, you can refuse treatment. And if that's all we got, the refusal of that treatment makes you ineligible. And you ask, why do they refuse treatment? The reasons why psychiatric patients often don't want to participate in our treatments. They're not motivated, they're worried about side effects, they're skeptical about efficacy. 20% have never been treated as inpatients, one mark about the intensity of treatment. So, that's a fairly good barometer of how hard treatment has been tried. So 1 out of every 5 were never inpatients. And these couple of treatments, this is more for clinicians, these are treatments, electroconvulsive therapy, monoamine oxidase inhibitors for depression. They're common treatments that we use for severe treatment-resistant depression. And a minority had those. When asked as the main reason, which people are asked as part of the euthanasia process, 66% cited social isolation and loneliness, something that's very endemic to the mentally ill. In 24%, although an independent consultant disagreed, they were euthanized anyway. So procedures were not really followed. And yet, the review committees that look at this after the fact said all cases were handled with due care. And the majority of them, 3/4, were euthanized by their own treating psychiatrist. Not somebody new, but somebody who had been with them for many years. And one of the things that I can tell you, when you are with somebody for many years, you can become infected as a clinician by their hopelessness, by their helplessness. I mean, it's a thing. We even have a term for that. If there are any mental health professionals in the audience, called projective identification, which can really metastasize feelings from the patient to the doctor, and you can go down that rabbit hole with patients. Now let's look at the end-of-life clinics. Look, there are almost 750 end-of-life clinics, these Lebensende clinics, and there the doctor is not usually the treating physician. They're new to the case, this is one famous critic there said, within the clinic, a group culture has emerged, and with euthanasia is considered to be virtuous labor, especially for severe dementia and psychiatric patients. Virtuous labor. So looking at the end-of-life clinics there, out of 645 requests in this one study over the course of a year, 162 were granted, 92 were killed in the clinic, 23 agreed to go back to their primary doc to have the procedure done. Of the 645, 121 were psychiatric patients only, and 6 of those were granted. So that's about 5%. I want you to remember that 5% number. We'll come back to it. The Dutch Psychiatric Association and Medical Association have published pamphlets to give their physicians guides about how to do this. So in that sense, they have endorsed this to show physicians how to proceed. It's gone beyond illnesses that you might be intuitively think would occur. It's offering euthanasia now for chronic alcoholism. This is a woman who was euthanized on request because she had tinnitus, something that shakes me up because I have a very severe case of tinnitus, something that I've learned to adapt to and survive. This woman was granted euthanasia for her tinnitus. Low IQ and autism is a paper just came out last month, 9 cases. And there the insufferable conditions were that the patients felt unable to cope with changing circumstances or increasing dependency. And that's very endemic to people with developmental disabilities. This documentary film, What's Best for Keys, an autistic adult, her mother is shown in the film saying, euthanasia is a sacred word for us. When we've passed away, for whom would Keys stay alive? His deepest wish is to go to sleep. He will be totally satisfied. Euthanasia is a wonderful option for parents of developmentally disabled kids. Well, there's been somewhat of a backlash there. In 2011, asked, would you ever be willing to give psychiatric patients, euthanasia actually was framed in the inverse. Would you consider euthanasia for psych patients to be inconceivable? In 2011, only 14 said, yeah, that would be inconceivable. But by 2013, 60% had felt, no, this is really not good. So the Medical Association published a new pamphlet. Just because we can doesn't mean we should. So a number of doctors are starting to oppose euthanasia. 220 doctors said, let's at least get rid of it for patients with dementia, because there have been some misadventures. But it's gone even further there. That it is now the Minister of Justice and the Minister of Health are trying to push this beyond medical criteria, to have simply people who say, I feel like I have a completed life. And as a matter of fact, the head of their leading party, the D66 Party, says, we have to take it step by step. In 2002, we passed the euthanasia law for unbearable suffering. We can now take the next step for our civilization. This culture feels that they are moral pioneers, that they are pushing the outer boundaries. They are creating a level of progressivism that really is considering the movement of the set point for what constitutes eligibility for euthanasia, far down the rail, and consider themselves to be visionaries. And even more, there's even a talk of taking it out of the medical domain, which frankly actually makes me a little bit more comfortable. Their Supreme Court, retired Supreme Court Justice Hugues Drian has published and pushed for this, so it's affectionately called the Pill of Drian in the Netherlands. And there's a push for that. In fact, Dutch Voluntary Euthanasia Society, which now has over 250,000 members, is pushing for the Pill of Drian. And this website has popped up, Last Cooperative Last Will, in the Netherlands, where you can sign up, and for a fee, they will send you the remedy. There's actually been a recent suicide. This is not yet legal, so just March 21st, just several days ago, after a teen's suicide that she got off this website, the Dutch are investigating, because it's not going through the medical channels that it's supposed to. Now, let's take a look at Belgium. I'm going to skip that. There's been a 900% increase in Belgium since their law came out in 2002. 1.8% of every human being who dies in Belgium dies at the hands of a physician. Remember, it was 4% in the Netherlands, because they don't have those clinics in Belgium. You actually have to go through hospitals and your treating doctor. With psychiatric euthanasia, you can see also an exponential increase. By 2014, I don't have data since then, there were 124 people that year. Most of them are women. 2/3 of them have a mood disorder. And in 83% of people with mood disorders, they were under 60. Most of the people who die by physician-assisted suicide are over 60 in these countries, except for the psych patients. They're more likely to be under 60. So looking at those 124 patients in 2014, here are some of the diagnoses that they have: schizophrenia, bipolar disorder, autism, dementia, depression, and this very severe form of personality disorder, the borderline disorder, which I won't get into. This woman you saw in the film, Lee of Tienpan, she's actually responsible for 70% of the psychiatric euthanasia. She's sort of the psychiatric Kevorkian in that country. She wrote this book called Libera Me, Free Me, on euthanasia and psychological suffering. So she looks a lot like Jack Kevorkian, actually, which is really puzzling to me. So it's kind of a sort of physiotype. So she published her first 100 patients, and they were all found to be competent to make this decision, even though 14 of them were psychotic. As a psychiatrist, that really beggars belief, that you could actually be psychotic and considered competent for this. Remember the 5% in the Netherlands? Well, in her series, it was 48% acceptance. So So 48% of these 100 psychiatric patients were granted their euthanasia card, and 73% of those have gone on, at least by the time this paper was written, to be euthanized either at home, like Emily, or in the clinic. And this shows you the diagnoses of those first 100 patients. I mean, it's really remarkable. Some of them, have attention deficit disorder, or complicated grief, or autistic spectrum disorder, substance abuse. Really, it spans the whole range of major and minor in quotes, psychiatric conditions. So basically, here's how the slope slips. In Belgium now, they've progressed. These two twins were euthanized on request after going blind. Here's a man who struggled with his homosexuality for years, very unhappy that he was a homosexual. They allowed him to be euthanized. Here's a transgender person who was unhappy after the third sex change operation. They allowed him to be euthanized. So there's been a backlash. The yellow jackets in Belgium are marching in the street about this. Palliative care nurses are very unhappy. They've been quoted, one was quoted as saying that the palliative care units are being turned into houses of euthanasia, and a number of the palliative care nurses are quitting. This guy who's on the review commission for looking at cases after they've occurred, he was so upset with how things are going that he resigned back in September. A whole host of intellectuals, professionals, societies, and so forth published in the newspaper a plea in 2015 to at least take psychiatric patients out of it. Let's at least take that step backwards. It did nothing. The Brothers of Charity, a Catholic organization that runs the majority of psychiatric hospitals in Belgium. You might imagine that they've been against euthanasia of psychiatric patients, and they were, up until April of last year, when they drank the Kool-Aid and they've decided, yes, in our Catholic hospitals, we will allow euthanasia to be administered. The Pope said, no, you won't. And the head of their organization, who's the former Prime Minister of Belgium and President of the European Council, said, the time of Roma locuta causa finita is past, meaning the time when Rome is spoken, end of conversation, that's over. We don't do that anymore. Just because Rome said it, aren't going to do it. They had a big conference at their largest psychiatric hospital. Like you, they were kind enough to ask as their keynote speaker somebody who's opposed to this. And so I was invited to give the keynote talk that day in September, trying to convince them they were headed down the wrong path, and I failed to succeed. So they are now in the possibly being either excommunicated or at least told to take the name of the Catholic Church off their hospitals. So look, this is how it goes, folks. In the laboratories where this has been deployed for many years ahead of where we are in the United States, it starts with the terminally ill, and then it progresses to the non-terminally ill. Then the distinction between physical and mental suffering is removed. Then children, since 2014, child of any age with proxy consent by parents can be euthanized in Belgium. Then they allow advanced directives where years before you can make that choice, such as with dementia. And then you get mandatory referrals by conscientious objectors, so that they're not allowed. Then, because of those openings, my guys start to get in line, psychiatric patients, starting with major mental illnesses, progressing to more minor conditions. Then it progresses to uncomfortable lifestyles like homosexuality and blindness. Then it progresses to the tired of living and those who have completed life, where it's hovering right now in Netherlands and the Belgium. Then it progresses to those who are not competent, which is starting to happen in Belgium now, where if you're not competent to make a decision, you can have it made for you by proxy, not just for children, but for people who have a guardian. And then it progresses, if you can't find a guardian and there's no family members, what's happening is mercy killing, where the doctors decide for themselves, we can't find anybody, we wouldn't want to live if we were in the condition of this person. And then it progresses to the pill of Drian, the over-the-counter pill, and then it progresses to the Sarco. What's the Sarco? Stand by. I I will show you about the sarco. So the pressing question, says a member of the parliament, is where the slope ends and the abyss begins. Will the day come when society considers it entirely normal or natural for people who grow old or sick to simply pop the pill and disappear? Or as Daniel Goldhagen, who wrote Hitler's Willing Executioners, talked about a transformation from a non-obligatory, optional occurrence to a moral norm. So let's just take a quick look here at some of the formal ethics and some of the ethical ideas. So the world's medical organizations and their ethical codes, which date all the way back to Hippocrates, what are they saying? The AMA stands at the moment opposed to any form of physician-assisted suicide or euthanasia, terminal or non-terminal. The American College of Physicians stands opposed to any form of physician-assisted suicide. That's the most important group of internal medicine physicians. The World Medical Association stands opposed, and says it is unethical and should be condemned. The World Psychiatric Organization, to which Belgium and the Netherlands belong, they're a little more wishy-washy. Well, we should be careful. The psychiatrist should be aware the patient might have distorted views due to mental illness. The psychiatrist should treat the illness. They're not really firm against it. Now, the American Psychiatric Association, to which I belong, one of the great accomplishments of my career is we are against all of it, but I felt we needed to make a statement specifically on behalf of our guys, a shot heard across the Atlantic. And so I politicked and negotiated and got passed as the official statement of the American Psychiatric Association. You heard my introduction, that it holds that a psychiatrist should not prescribe or administer any intervention to a non-terminally ill person for the purpose of causing death. Now, we're against it for the terminally ill as well, but we felt we needed a special statement because of what's happening to our guys and overseas and soon in Canada. So what are the arguments in favor of this? The arguments in favor of this mostly argue from justice or parity. The idea that mental suffering and physical suffering really can't be and shouldn't be distinguished, that suffering is suffering. It further asserts that just because you have a psychiatric illness doesn't mean that you aren't competent and that you could be just as competent as a medical illness, and that the usual standards that we use for things like should you have surgery or can you refuse a medication, as opposed to have an irreversible death, that they should apply. And so therefore psych patients are capable of rational suicide. That you can't exclude any class of people. That you can't say it's okay for non-psychiatric conditions, people, but not okay for psychiatric people. Once you've opened the door, that the demands of justice are that you can't exclude a class. Also, that it says that that so-called first level that I showed you of the three is morally equivalent, that withdrawing treatment, getting out of the way of death, is really morally equivalent to actually killing. And we can talk about that and debate that. I will tell you that people who think very deeply about that say that no, those are actually not equivalent. To get out of the way of death, to make somebody comfortable, is not the same as actually taking their life. But this is the argument. Obviously, it's driven by autonomy and self-determination. Those are considered the highest values, and that the role of a physician beneficence to do good, to relieve pain, to relieve suffering, if you have to kill the sufferer to achieve that, that is a beneficent thing to do. And that if patients have a right to have this, that implies that if it's a patient's right, therefore it's the physician's duty. It also assumes that there's such a thing as untreatable psychiatric cases. We do not recognize that there's such a thing as untreatable psychiatric cases in the United States. But once they created the category, the silo, if you will, of untreatable conditions before psych patients were allowed, once you created that silo, it started to be populated by psychiatry and psychiatric patients to say, well, we fit in that silo too. So in Belgium and the Netherlands, the idea of an untreatable illness, as opposed to an illness that is difficult to treat or patients don't have access to the appropriate treatments, that is recognized there in a way that it's not. The idea that for some people suicide is inevitable, so they need to have an option and a more certain method than traditional suicide that might even be able to include their families, so they'll be less shocked, and that, like Emily, peering over the edge will be a deterrent to suicide for many, and also that it's a virtue opportunity to turn adversity to virtue, to have a young person whose life is really not meaningful to them be able to donate an organ, and this is something that is actually emerging. Here in Switzerland, which we didn't talk about, their exit network talks about how this is actually an effective form of suicide prevention. But more importantly, I want to show you this organ donation issue. As of 2015, it's happened way more than that, but this paper from there shows there have been more than 40 donations of organs in the Netherlands. And now there's a new law as of February of this year that you're an organ donor by default. You have to sign a card if you don't want to be an organ donor. And remember, who have the most desirable organs for donation, right? Psychiatric patients who are young, who are medically well, who have all of their organs intact, maybe not their brain, but we don't do brain transplants yet. And so they are being induced, and in fact there's national conference in Netherlands every year for the youth to get them on board with this idea of euthanasia being their right and their privilege. And in this annual conference of youth, there's a whole workshop on organ donation and how you can make virtue of your suffering. I'm going to skip this. This is actually a little interview with a guy. So look, the fact of the matter is that these countries have been running autonomy off the rails for a long time. Legalized marijuana, prostitution, and in fact, some ethicists have called it the fetishization of choice, the apotheosis of autonomy, where autonomy has become the single most important ethical value. In the interest of autonomy, we all, including the medical profession, needs to bend and serve a person's autonomy as if there were no other values. In psychiatry, this is a real problem. First of all, in order to know what the prognosis of a condition is, you have to know what the condition is. And we in psychiatry have some unreliability when it comes to making a diagnosis. Diagnoses change. We do not have another domain of validation as to what a person has, like an EKG or a chest x-ray. Another domain of validation in which we can say definitively what the condition is. We are phenomenologists. We look at the clinical history, we look at the clinical experience, and that can morph over time. So if you don't know the diagnosis, then you don't know the prognosis. We have complex comorbidities. Often patients have more than one problem in the domain of states like depressions and psychosis, and in the domain of traits like personality disorders and substance abuse. There are complicated psychosocial forces at work. People are often not truthful about their history. And there's so many treatment options that are available in psychiatry. And those options may be expensive, especially in this country, may not be accessible to people because of their insurance plans and their finances. Don't fool yourself into thinking that they're also available, that they are available in socialist countries that have socialized medicine. My trip over to Belgium revealed to me that, as a matter of fact, no, not all treatments over there are readily accessible and readily approved. As a matter of fact, there's one treatment for depression that's not commonly used, but it's available, called deep brain stimulation, where you implant a stimulator in a person's brain. The hoops that you have to go through in Belgium to get that approved and financed by the socialized medicine system are 10 times more elaborate than the hoops that you have to go through to get approved for euthanasia there. Before we try assisted suicide, Mrs. Rose, let's give the aspirin a chance. And it is very dependent on the particular practitioner and doctor that's making the decision. That the willingness to endorse assisted suicide is inversely proportional in this study of 1,000 physicians and other healthcare professionals, inversely proportional to the religious belief, their knowledge of symptom management, their knowledge of palliative care, the amount of time that they feel that they have to help people and manage symptoms and not being rushed, the degree of worry that they have about opiate toxicity and so forth, a big issue now that's playing out in end-of-life scenarios as well. But the thing is that this also creates shortcuts that might be available to exhausted families, which is especially true in people who have chronic mental illnesses. Exhausted treaters, insurance and payers that are trying to control their costs. And then the tremendous dichotomy of messages as we try to promote suicide prevention on one hand, and yet this on the other hand. With regard to finances, this is a case in Washington where a woman, terminally ill woman, wanted to live a few extra months to attend her daughter's wedding. Her insurance company did not approve the expensive chemotherapy, but it did approve the $150 package of barbiturates for her to have assisted suicide. Here's a man in Canada who is in a nursing home with a degenerative disease, and they've offered him either forced discharge from the hospital, or medically assisted death. He's actually suing the government for life with dignity as opposed to death with dignity. This, I think, picture speaks 1,000 words. So we have the suicide prevention program on the left, the assisted suicide program on the right, and here's a guy in a wheelchair, and you can see which side the ramp is on to allow him easier access. So with regard to a claim that this will be an alternative that might actually discourage people from suicide, or versus the worry that suicide can be contagious, and we know this is a real phenomenon called suicide contagion. So this shows you the suicide rates in comparable countries over in Europe that are somewhat similar socioeconomically: Finland, France, Germany, and Denmark. You can see the suicide rates are steady or lowering over the course of the last 13 years. But in the Netherlands, you can see that since they began their suicide law, that the overall, this is the natural suicide rate, not the assisted suicide rate, wild type, usual suicides are actually starting to grow, arguing about at least the possibility that there's a suicide contagion. Certainly not the possibility that having this option is discouraging people from ordinary suicide. So look, let's distinguish the difference between freedoms and rights. Freedoms are liberties that cannot be interfered with, such as the freedom to own property. But a right creates an entitlement. So you're free to own property, but your society, your government doesn't have to give you properties. But you can have your property, but you don't have to be given anything. Well, heretofore, suicide has been a freedom, although, by the way, not always. It was really up until 1984, Virginia was the very last state to remove the law that made suicide illegal, interfering with your ability to inherit and so forth. And in many countries still to this day, including India, by the way, if you attempt suicide, you can go to jail. But since 1984 in the United States, suicide has been a freedom. What these laws are doing are really transforming suicide from being a freedom to being a right. And when you have a right, then somebody has a duty. Society has a duty. So if you have a right to vote, society has to provide voting machines and mechanisms whereby votes can be expressed and counted. So the question is, if it is a right, and Kevorkian certainly thought it was a fundamental American right to life, liberty, and the pursuit of happiness, then the question is, whose duty is it? And I really want to submit to you, terminal or not terminal, psychiatric or not psychiatric, that this venerable and powerful and important ethos of medicine, that it is actually not the physician's duty, just because it's a patient's right. So the question is, if it's not the physician's duty, then whose is it? And frankly, it's the government that gives those rights. It's their duty to provide the right. So if it's not physicians, who's it going to be? This is Charles Sanson, the fourth generation in 4 generations of royal executioners in France. And as a matter of fact, Virginia had its own state executioner until 1999. So this idea of laicide, okay, let's stand up an alternative profession, thanatologists, laicists, who will be able to provide this. But killing, I am maintaining, and in my activism, but especially on behalf of my psychiatric patients, does not belong in the House of Medicine. As John Mayer, the editor-in-chief of the Journal of Ethics and Mental Health, so poignantly said, there's something critically important about keeping the role of bringer of comfort and bringer of death, keeping them separate, even if they are arguably on a conceptual continuum. And then we have the Sarko. So this Dr. Nitschke has developed this device where you can take an online test, and through the online test, you will automatically be judged either competent or incompetent. And if you are competent, no matter what your condition is, if you are competent, you are, these vessels are placed in a variety of nations. Now, I think there are about 9 of them around the world. You can be given the code to go to one of these things, and it will open, and it will close you in, and it will fill up with nitrogen, lowering your oxygen level to 5%, where you will gradually pass away in 1 minute. The Sarko. And that's sort of where we are at in the slippery slope. And what about psychiatry? I think that this inverts the fundamental ethos of what it means to be a psychiatrist. Scott Kim, who actually collected a lot of the data, he's at NIMH, that I've shown you, he writes, a core clinical imperative in psychiatric treatment is compassionately and skillfully helping patients even through periods of sustained suffering during which people often lose the will to live. Suicide prevention is a fundamental core mission of what we do every day. We help people find a path to a better future. We help people cope with suffering and demoralization. We help people deal with the strong and elaborate psychosocial pressures that may be interfering with their recovery or creating this demoralization. We try to help reduce suffering as much as we can, and if we can't completely reduce suffering, we have a skill set in the mental health professions to help people actually make meaning of suffering. So this is what we do, and to have psychiatrists actually killing their patients is an anathema that is, I am maintaining, an inversion of our fundamental ethos. John Mayer again, just as the Pope should not perform abortions and the Dalai Lama should not take up arms, a psychiatrist should not counsel or abet suicide. For in doing so, we've misunderstood and betrayed our vocation and profession. Validation of suicide or assisted suicide by psychiatrists is therapeutic and professional hypocrisy. But I want you all to understand that this step is not just important with regard to my profession, my patients, mental health domain at all. This is a very important development in the remarkable experiment that's going on in countries that have been at assisted suicide and euthanasia a lot longer than we have, and part of an incredibly accelerating slippery slope that's all the way down, as I showed you before, to the Sarko. My mentor, who was the former chairman of psychiatry here at Hopkins, wrote back in the Kevorkian days, he wrote, patients are seduced by isolating them, sustaining their despair, revoking alternatives, stressing examples of others choosing to die, and sweetening the deadly poison by speaking of death with dignity. If even psychiatrists succumb to this complicity with death, what can be expected of the lay public? And finally, the great medical ethicist, Leon Kass, one of our revered heroes in this domain in the 20th century, said, when physicians themselves, as in Holland, undertake to kill their patients with public support, intuition and revulsion have fallen asleep. Only argument, with all its limitations, can hope to reawaken them. And I hope that I have awakened some of those sentiments in you today. Thank you.